Diabetes during pregnancy, how to control it, and how it monitor. See, nowadays, a common complications which is occurred in any obese female during pregnancy, it is a diabetes mellitus, and which is also known as gestational diabetes. In 2018, ICMR has given clear guidelines regarding to detect gestational diabetes. Few of the points are here. What is pre-gestational diabetes? A female who have type 2 or type 1 diabetes prior to becoming a pregnant are said to have pre-gestational diabetes. And for good maternal and fetal outcomes, they should do regular checkups and tight control on their glycemic control. For this, these points will help them. Number one, tight glycemic control like HbA1c less than 6.5 is very good. Number two, folic acid supplementation should be taken. Number three, eyes and kidney function tests should be done. Nutritional status must be maintained. Folic acid supplementation should be taken. Antihypertensive agent should be changed to calcium channel blockers or alpha methyldoma. ACEIs or ARBs and diuretics and statin should be discontinued. Maternal and fetal surveillance during pregnancy should ideally be done by obstetrician and physician. It's all about the pre-gestational diabetes. Now let's talk about the gestational diabetes mellitus, which is also known as GDM. Glucose intolerance or any severity detected for the first time during pregnancy is termed as gestational diabetes mellitus. And ICMR guidelines for management of type 2 diabetes are as follows. History of GDM, second close blood relative with diabetes like maternal, paternal, uncles, auntie and all. History of large weight babies like more than 3.5 kgs baby. Bad obstetrician history like stillbirth, congenital anomalies, recurrent pregnancy loss, eclampsia, hydramnios like accumulation of excess amniotic fluid, urinary tract infection are above than 25 years. Screening method for GDM is ideally done at the first trimester mainly to rule out pre-existing diabetes. Second, fasting glucose is equivalent or less than more than 126 mg per dl. The random glucose is equivalent or more than 200 mg dl. HbA1c is equivalent or more than 6.5%. At the second trimester, between 24 and 28 weeks of a gestation, and oral glucose tolerance like OGTT can be done, should be done using a 75-gram glucose load. Like fasting plasma glucose should be more than 92 at 1 hour, more than 180 at 2 hours, and more than 153 after 2 hours. And if any of these values is above these cutoffs, the woman has GDM, where pregnant women cannot be tested in a fasting state and in resource limited setting. So this is all about GDM. Managing GDM and pregnancy gestational diabetes, two important factor is exercise and second is medical nutrition therapy. Both are very important. Only if they fail, then medical emergency or management must be started. Medical management, they start insulin, and insulin is a preferred drug. Human and regular insulin they preferred. Mostly metformin is also used in GDM. And however, glycemic control, fetal growth and maternal blood pressure need to be monitored continuously. Number one, the nutritional management of diabetic pregnancy. See, there are specific nutritional issues that surrounded the management of pregnant women with diabetes. The nutritional need of women with pre-existing type 1 diabetes and type 2 diabetes differ from those for women who become glucose intolerant in pregnancy. Okay, ideally, nutritional advice should start before pregnancy and should be modified at each visit by the dietitian, who is an internal part of that hospital and center. And diabetic obstetric team also. The dietitian must take into account metabolic and physiological changes associated with the diabetic pregnancy. And over the last few decades, the antenatal population has become older, more obese, and less physically active. These changes explain the rise in the number of pregnant women with the pre-existing type 2 diabetes and gestational diabetes. And it is very important that the perinatal morbidity and mortality in diabetic pregnant woman is higher than the non-diabetic pregnant woman. Active dietary management for all type of diabetic pregnancies can lessen complications during pregnancy and improve pregnancy outcomes for the mother and child. Number two, consequences of diabetic pregnancy. Maternal hyperglycemia result in excess maternal fetal transfer of glucose, which result in fetal hyperglycemic and fetal hyperinsulinemic, and this can lead to congenital malformations, and diabetic mothers are soon to deliver large for gestational age LGA infants, especially in poorly controlled diabetic pregnancy. By managing the diabetic pregnancy effectively, one can reduce the long-term risks of the child becoming obese and insulin resistant in adult life. Number three, therapeutic aim. The aim in the management of all diabetic pregnancy is to advise normal glycemia while avoiding maternal hypoglycemia, and this approach will optimize fetal growth and minimize short and long term complications. Women with a gestational diabetes GDM will be able to achieve them with dietary interventions alone, and the use of oral agents that do not cross the placenta or insulin should be done under the medical supervision. Dietary advice must be based on a sound nutritional principles and the patient closely monitor. Folic acid supplementation is necessary as for the other non-diabetic pregnancies. Women with diabetes must be encountered to achieve the best glycemic control during the preconception period, and congenital malformations can be significantly reduced when HbA1c levels are within the normal range. Dietetic input is required to build confidence, reduce hypoglycemia, and limit unnecessary weight gain. Achieving near normal glycemic control is possible, and in most women with the type 2 and type 1 diabetes. However, in women with a long duration of type 1 diabetes and significant autonomic neuropathy, the risk of severe hypoglycemia is high. The diet counselor must ensure that adequate carbohydrate intake and the low glycemic index snacks are being ensured between meals. A weight reducing diet in obese prior to conception has been shown to improve both glycemic control and pregnancy outcome. Number 4, some general guidelines for diabetic pregnant women. Once pregnancy has been confirmed, the diet must contain adequate amount of calcium and vitamin D, as well as must take supplements during both pregnancy and lactation. The recommended intake of minerals, vitamins include folate and iron. Adequate amount of antioxidant including vitamin C, E to reduce the risk of preeclampsia and congenital malformation is important. Nutritional intake should be monitored from the beginning of the pregnancy, and calorie intake should be adequate. Calorie requirements are based on pre-pregnancy weight, height, age, activity level, and usual intake. In the first trimester, the daily calorie intake should be between 30 and 38 kilocalorie per kg of the ideal pre-pregnancy weight. This should be increased to 36 to 38 kilocalorie per kg of ideal pregnancy weight. Beside adequate calories, pregnant women need adequate protein. 0.75 gram per kg per day plus additional 10 gram per day. The meal distribution will generally be 3 meals and 3 snacks. Space around 2 hours